Hi, I am Dr. Beverly Reed.
And I'm Dr. Klimczak.
And we are Two Peas in a Pod. Welcome back, everybody. All right, Dr. K, I've got a celebrity story for you.
Oh, gosh, I hope I know them.
This is an older one. It's a Kardashian. You know I love my Kardashians.
So true.
And there's so many of them.
There's a lot of them.
But admittedly, it's one of the older fertility stories, but this is about Kim Kardashian.
Okay.
And a long time ago, she did end up undergoing IVF. And from what she shared, I think I'm actually not even sure how many cycles she did, but ultimately she got to the point where they needed to figure out which embryo they were going to put in. Okay.
She had multiple to choose from.
Yes.
She's exactly. a good position to be in.
Yes. And this is always a hard decision for patients just in general. Which embryo should we put in? And ultimately, she did choose the highest graded embryo to put in. And I would say that's probably what most people choose, right? I'll talk about some exceptions to that. And so I thought maybe we could talk about embryo grading overall. We did actually have a special request this week to talk about embryo grading. And I do feel like this is probably one of the things that stresses my patients out the most, embryo grading. Do you see the same thing?
Yes, I think it's something that it feels black and white that they really grasp onto. And I think from our side of things, it's really not black and white. It's something that can be very subjective. And so it's hard for me sometimes to relate it properly, I think, to my patients, because we'll talk more about it, but it seems really straightforward when you hear an embryo grade. Like your letter grade in school, you're like, well, either and it's just not quite that simple.
And I think even the concept of giving an embryo a grade is a funny concept if you think about it. We don't really grade people. Okay. And even, for example, in a pathology lab, when somebody sends tissue, you don't grade tissue overall. So it's odd that we would grade embryos to start with. But I do want to explain just to our general audience, what we're specifically talking about is patients that are undergoing IVF, in vitro fertilization. We stimulate the eggs to grow in our patient. We pull the eggs out. We add their partner's sperm to grow embryos. And then the embryologist looks at each embryo and assigns a grade. And I think, number one, there's so many different ways to grade, right?
Yes, definitely. There's different systems that are used by different labs, even maybe different embryologists within the lab can use different systems. And so we can talk about a few of those, but I think there's more widely accepted ones that probably more people have heard of and you probably can relate to. But sometimes even if you ask your friend, if they're going through IVF at the same time as you, hey, what was your embryo grade? They might tell you something. You're like, I don't understand. That doesn't sound anything like my embryo grade.
Yeah. And can I tell you too, sometimes if a patient has done IVF elsewhere, and I'm asking them and I'm looking at their records, sometimes I'm even looking at their grading and I'm saying, wait a second, this doesn't look like a traditional grading system. And even I have to kind of look into it as a fertility specialist sometimes to figure out what system they're using.
Definitely.
So, okay, let's kind of talk about probably one of the more common ones. And I would say most people use the Gardner scale to grade embryos. And I would say I usually see a couple modifications on that, so we can talk about it, but maybe we can just start with kind of each component of it. So for most people, they're going to get something that has three things: a number to start with, and then two letters. And so maybe we'll talk about the number first. So do you want to talk about what does that number mean for grading?
Yeah. So an embryo is round. If you can imagine, it's a sphere, but when we look at it under the microscope, it's just like a circle because we're seeing it in a 2D plane. And so when we look at the size of the embryo and how expanded it is, that is the number that you're going to see at the beginning of your embryo. And the size or the expansion can change as it starts to actually hatch out through, we'll call it the shell of it, through the zona, right? It will start to hatch, and then sometimes they can completely hatch out. So the number that's given to it really depends on how big is it getting and how much has it hatched out of its shell or even completely hatched out.
Yes. And one of the common questions that I'll get about this part of the embryo grading score is what is considered a good number. And this is interesting because you would think maybe the highest on the scale might be the best number, but that's a little bit controversial, I've seen. And the reason for that is a 6, that's the highest. A 6 means the embryo has completely hatched out of itself. And that's great. It means that embryo is growing and advancing and everything. But here's the thing, sometimes those can be a little bit more difficult to actually transfer because without that protective shell, sometimes it's even harder to survive the freeze and the thaw. But then even in the embryo transfer catheter, because they don't have their shell, they're so sticky that you want to make sure they didn't stick behind on the catheter as you were doing the transfer. And that's something we routinely check for anyways, every single time we do a transfer. We have the embryologist look into the microscope at the catheter and say, did the embryo stay in the catheter or did it actually go in the patient? We double check those things. But I think that's why maybe more people would say an ideal score would be like a 4 or 5. What do you think?
Yeah, I love 6s.
Oh, you do?
In terms of a true beauty contest, like if you needed to post a picture of an embryo,
that's
a 6 is just so gorgeous
because
they're like completely out of their shell, like they're hatched, they're just like perfect little embryos. But I agree, and this is actually something that's changed as I've moved to different IVF centers because I think it's an embryologist's preference, really, in terms of whether they prefer to freeze an embryo with partial shell around it or not. I used to transfer, I feel like, a lot more 6s, and I know that our embryologist prefers for them to have a little protective shell. So I hardly ever see 6s now in our lab. Do you feel similar?
Yeah, I think that's the same. We prefer the ones with a little bit of shell. I think your favorite stage is the 6. I would say my favorite's the 5 because I think it looks really cool when it's partially hatching out. I'm like, that's a picture perfect embryo there. So. But I would say this too. Does that mean any of the lower grades aren't good? I wouldn't say that at all. I'd say a 3 is good, a 4 is good. I don't really see 1s or 2s very often because usually if they're small, we'll try to get them to keep growing, right?
Yeah, a 1 or a 2, they'll typically, during the process of development, the embryologist might mark that, like if they're checking an embryo early, let's say on day 5, it's not quite ready, they may mark it as not as expanded, but they're not going to yet biopsy it or freeze it. It might be marked as that. But I feel like for the most part, they're going to wait for a 4, 5, 6 to go ahead and biopsy and freeze.
Yeah. Okay, let's move on to that kind of middle digit there. So the next part of the embryo grading score is a letter. And this is a little tricky because it depends on if you're following the actual Gardner scale versus if your lab has made a modification. Because the letter may be A to C or A to D. And I do think that's important for interpretation when patients get these results. And sometimes they go Googling, and because maybe they're misunderstanding the scale that's used, sometimes they may attach a different significance to their grading results than what would actually be the case. But that middle digit is specifically grading the part that is the inner cell mass, which is the part that would eventually become the baby if the patient's pregnant. And can you tell me, because, and here's the thing, Dr. K actually has special experience in this. She has worked in an embryology lab and she got to grade embryos. So can you tell us what would make an embryo or an inner cell mass an A versus a C or a D?
Yeah. So the inner cell mass, if you can imagine, it's almost like a ball of a bunch of cells, okay? And that ball can maybe have not so many cells and be really asymmetric and maybe even have some pieces kind of breaking off, fragmenting off of it, and not look so good. Or it could be a nice, tight little ball of cells with tons of cells when they pull it in and out of the microscope and look at it in a 3D field, and it looks very symmetric, right? And so typically we assign the prettiest, the most symmetric and cellular inner cell mass will give an A. And then maybe if it's not so symmetric and has slightly fewer cells, a B, and then C would have even maybe more fragmentation or not as much symmetry, not as many cells, right? But still to the point that the embryologist feels this is an embryo that is able to be frozen and has reproductive potential.
Awesome. Okay, so then we've got our last part of the grading. So this one's going to be another letter, which can go from either A to C or A to D. And this next part is grading the part of the embryo that will ultimately make the placenta. We call this the trophoblastic cells. And so can you tell us a little bit about what could distinguish between that as well?
Yeah. So the embryo, we talked about the inner cell mass, and then you have the trophectoderm, which is actually just almost like a little line of cells all lined up around the circle around the inner cell mass. And these cells can look interesting. I would say with the higher graded trophectoderms, they're really nice and plump cells. There's a lot of them, very symmetric, right? Look nice and circular. And to the embryologist, especially if they're going to take a small sample of them, a biopsy to send off for testing, they want them to be nice and juicy, right, and have a lot there. But sometimes it can look shabby, right? It might not have a lot of cells, really thin and flat trophectoderm cells, maybe fragmentation, little pieces breaking off around. So that would be more so like a lower graded C. So you can see it's just like a spectrum for them. They look at it, they see how many cells are present, what do those cells look like.
And so now that we talked about each individual component, when somebody gets their grading back, it could be, for example, anywhere from a 5 or 6 AA, an amazing looking embryo, or it could be something like a 1DD or 1CC, and then anywhere in between. And I do think this is so hard because I actually bring this up when I'm talking to people about IVF to start with. As I say, look, when you're sitting in this chair, you and your partner are thinking, of course, our embryos are going to be AAs, right? Why would they be any less? Mine were. And that's all. And I love the positive thinking, right? But really, what's most common, what would be more an average kind of grading, it's going to be lower than that, right? And so I think it's good first to just set expectations that these 5 to 6 AAs are pretty rare, and that the average person is probably going to have lower grading for an embryo overall.
Yeah, definitely.
Yeah.
And just like in general, setting expectations that your embryo is going to get a grade at all.
Yeah, that's true. Yeah.
It's just kind of shocking when someone calls you and they're like, oh, your embryos are B's. You're like, B's? I want A's.
Yeah. Okay, but then this is a really important point. I almost wish I had my slide that I usually show patients is, what can embryo grading actually tell us? Okay, so number one, and this is probably the most important point, is embryo grading cannot tell us if an embryo is genetically normal or abnormal. And it still even surprises me, even though I've been doing this so many years, is I've seen a beautiful AA embryo be completely abnormal and one that we knew we shouldn't even use. And then I've seen a CD embryo be genetically normal. Grading tells you nothing about genetics, right?
Yeah, definitely. So I actually participated in a study that I think is relevant here when I was in fellowship. I will say, remember, the person assigning the grade of your embryo is an embryologist. And in general, embryologists are actually very good at choosing normal genetic embryos without realizing it. If your embryos are not going to be genetically tested and they're just going to choose based off which one of your embryos in your group or your cohort of embryos is the prettiest or highest graded, that is more likely to be a normal genetic embryo. We actually have the data to back that up. So I think that's important also to understand, because that's where a lot of the confusion comes about the difference between tested embryos and not tested embryos, because even if an embryo is not tested, it is having a selection process that the embryologist is going through. It's not just a random selection.
Sure. And I think since you brought up grading too, in terms of the embryologist, it's so hard because you'll see strict graders and easy graders. Just like we've all had teachers growing up in school, some teachers will just dole out the A's and other teachers are so strict. And I will say, my opinion is our embryologist is very strict, don't you think?
Absolutely.
She's always the strictest I've seen. And she's almost proud of being strict.
Yeah, she gave my embryo that grade.
I was like, come on. Dr. K could never have a poorly graded embryo. Hers has to be.
My husband was like, what? But yeah, another interesting study, my mentor actually looked at this. They would show slides of pictures of embryos to embryologist clinics and have them graded, and then actually show the same ones without realizing it to an embryologist. There's, of course, inter and intra observer variation in grading. So you can show the same picture to an embryologist on a Monday, and then on Wednesday they might grade it differently.
Before on their mood.
Yeah, before or after lunch. Everything with humans, we kind of feel differently. So highly subjective. It really depends on who's grading and maybe when they're grading it.
Okay, then I'm interested because I know you used to grade embryos. Were you a strict grader or were you a nice grader?
I feel like I was right in the middle. Okay. Because I was so fearful that the embryologists were going to tell me I was wrong. So you really hedge for whoever you're working with, right? That was like the story of making them laugh.
You know what I would be, right?
Oh, beautiful. Yeah,
I would
like,
be like, it's okay, little embryo, you can do it. In my eyes, you're an AA, even if you're C. I would be too nice of a grader. So probably good to just have balance. Here's a common situation I would end up in, and you have to tell me if you have the same thing. I call my patient and give them the embryo updates and say, okay, great. Then they call back. A couple hours later, they Googled.
Yes.
Okay. And in particular, if their embryo has the letter C in it anywhere, they've Googled, they're panicking, they're calling. Do you see that happen?
Yeah. But I try and maybe squash some of it on the phone call before I get them. It doesn't always work.
Yeah.
But yes, I agree. Because I think people just have concerns, especially because the letter C in an embryo, like we just said, can mean all sorts of different things to different people out there grading. But the question that you really want to ask your doctor is, in your lab, what is the reproductive potential of embryos that have a C in it? In our lab, it's very good. Yes. And I really give my patients that reassurance, especially if maybe that's the only embryo that they're working with.
Definitely. And I think number one, too, is that there's very limited educational information out there about C-grade embryos. And in fact, now we can actually refer them to this podcast, too. And, hey, here's your grading, and you should listen to our podcast about it. And here's why. So I will say there are many labs across the U.S. that if they see an embryo with a C in it, they actually do not use those embryos. And because of that lab may not know the potential of an embryo with this, and in fact, there's not very many studies. And I understand why some studies don't include those embryos. They want to make those studies applicable for maybe the average IVF cycle. But because we have that lack of data, that lack of information, I think it's really hard for patients to know and understand what is going on. But 100% what you said about it depends on the lab. It's so important to ask them, what's your data showing for your lab? Because I've been other places before and I've looked at the numbers where having a C in the embryo really did lower the reproductive potential, so lower implantation rate and even higher miscarriage rate. However, even in those cases, I always say give them a chance because some of them still work too. Maybe it didn't work as well as an AA, but why would you not want to at least have the chance to use an embryo, even if it's not as high chances as some of the other embryos available too?
Yeah, and some of the data that I'd like to see is obstetrical outcomes, even with differences in the grading for the trophectoderm and the inner cell mass. Like something that I was curious about is if you have a lower score for your trophectoderm, which ultimately becomes the placenta, is that associated with any obstetrical outcomes or any placentation disorders?
Definitely.
I've been very curious to see that. I'm surprised no one's looked at that before. Yeah. And again, it's so variable, right? It's based on lab, but I think it's something that we can even in our patient population.
Yeah, absolutely. But one thing that I do think is helpful when we're in particular looking at that trophoblastic tissue is if you have a lower graded trophoblastic tissue, sometimes we will talk with the patient to think about whether we still want to do genetic testing like maybe we had planned to do in the beginning. Now, I will say this is probably not common elsewhere because this actually does take a lot of time because in that moment, once you know the grades, that's when sometimes you may reconsider your decision to do genetic testing based on direct advice from the embryologist. But even, let's say the embryologist grades an embryo as a C, she may grade it as a C and feel like, hey, there's still plenty of cells for me to sample, versus she may give it a C and say, you know what, part of the reason I gave it a C is these cells look really fragile or there don't look like there are many of them. I'm just worried if I do take a little sample of these cells, could there be the potential that this could impact the reproductive potential of the embryo, even if it is genetically normal?
Yeah, and that's a rare thing, right? Most of the time we don't have that concern with embryos that are grown all the way out to day 5, 6, or 7, which are called blastocyst embryos. But yeah, occasionally remember the trophectoderm, that outside part, that's what we're trying to rely on to implant, right? To attach inside the uterus. And so you worry if you take away too many of the cells and it already wasn't so good, maybe you're even impact its ability to stick and plant.
But the hard part is there's not really much data on that because we know if you have a highly graded embryo, A's or B's, there is clear data showing that doing genetic testing does not harm the embryo in any way. What we don't really know is what about a lower graded embryo? Because remember, some people don't even use those at all. So it's a bit of an area that really needs to be studied further. But back to our lab's own data, we've been following our data very closely, and if an embryo has a C in it, it is performing as well as that use in the bees too. And so that's why we can confidently tell our patients in that situation, hey, based on our data that we have so far, which we've only been open a little bit over a year, we've actually been seeing really positive results. Now, that may go back to the fact that maybe Dr. Yang is a really strict grader to start with, right?
Yeah.
Somebody else's C, maybe somebody else's B, for example. And again, that's kind of what makes it steady. But one topic of interest that I think, which I know you'll love because you love AI and ChatGPT and things like that, is the potential for AI to help us with embryo grading. Have you seen anything about this recently?
Yeah, tons. It's all over the conferences, all over medical conferences. They're really trying to figure out how can we use a computer creating these embryos for symmetry, for cellularity, and maybe taking out a little bit of that subjective nature of grading. But again, everyone just wants to know, what are the outcomes? Is it actually going to predict? Because even with grading, it doesn't necessarily predict the ability of an embryo to make life-healthy babies. Okay, we're getting better at grading, but are we getting better at getting people pregnant? That's the disconnect.
Exactly. And ultimately, I've seen AAs not work, and I've seen CDs be the cutest little babies ever. And once you know that, that's where it creates a lot of stress for patients. Because really, sometimes I ask, and I know we have to disclose grading, right? But I feel like it's almost harmful to people in so many ways. I think it would probably be psychologically beneficial to just say, you've got 3 embryos. Let's try to use them. But sometimes I talk to patients about this, and they're like, yes, grading causes me pain, but also I have to know. I can't not know.
I have these all the time. I actually have a patient that we called today that has a positive pregnancy test to transfer first embryo, highly graded embryo, did not implant at all. Second embryo transfer, slightly lower graded. And the couple's worried. Oh my God, we already used our good one. This one's not going to work. This is really frustrating feeling. And then this embryo implants. Like, we just don't have the ability to predict it by looking at it.
Okay, so I wanted to also just talk about now, so we've got our grading back, we're about to do our transfer, and we always ask our patients, which embryo do you want to put in? And a lot of times, people are wanting to choose based on gender, but if they're not wanting to choose based on gender, you would assume most people would want to pick the highly graded ones, right?
Yes.
Yeah, so have you ever had somebody who purposely didn't want to do that?
Yes.
You have? Okay, I thought it was only one.
No,
I have a few.
I have this situation. It actually sometimes is like a special situation, maybe where people don't like the way their transfer cycle is going for one reason or another. And then maybe they're like, my lining looks so much thicker this other time, but I don't want to waste this cycle. Let's just get a bad embryo.
Yes. Yes, I still remember one of my patients. I think she actually listens to the podcast, so she'll know that I'm talking about her. She really surprised me because she did her IVF cycle. She got genetically tested normal embryos. Some were highly graded, some were lower graded. Her lowest graded embryo was a CC embryo. Okay. And so we're getting ready to do the transfer. I say, hey, I'm assuming you want to put the best one in. She said, no, I want to put the worst one in. And I thought, why would you want to do that? And this looked like a beautiful cycle. Perfect lining, hormones were great. Why would you want to put the worst one in? And poor thing, she had been through losses before, miscarriages and everything. Her brain had been through a lot of trauma at that point. And she said, if I did a transfer of my most highly graded embryo and it didn't stick, it would psychologically crush me. And so she said, look, if I put the worst one in and it didn't stick, I'd feel like, hey, that was the worst one. I still got a lot of other chances. And so I said, I told her that I agree with this, and she was in the medical field too. I'm like, I know you know what you're talking about. It sounds like this is a very informed decision. Let's do it. And then, sure enough, her little CC stuck. And she got pregnant. She had her baby. Her baby is adorable. And she has been really helpful because she was one of the people who had Googled her grades. And after Googling, she had called and said, should we just discard these embryos? Are they not good embryos? And ultimately getting to see her baby really just feels like this is her way of helping other people. And so she's even let me share the photo of the baby and show people this is what a CC baby can look like. She's so cute. She's so healthy. There's nothing about the grading that would make us have concern. Like sometimes people say, could a poorly graded embryo have birth defects or problems like that? No, there's no correlation between that. It's sometimes just something we more so just judge, could this embryo have difficulty surviving a freeze and a thaw, or could it have some lower reproductive potential, but again, can depend on the lab. But anyways, just going through that with her, I saw, again, you got to give every embryo a chance,
Yeah, like gives me chills. Oh,
yeah.
Oh my gosh, good for her.
And then, okay, I have another funny story though. This is one of my friends. We had been friends even before I was a fertility doctor. She had done IVF, and she, of course, transferred her most highly graded embryo first, an AA. She got pregnant, had a baby, and then she kept doing transfers. So she has 4 girls. But she tells her girls, she's, yep, you were my AA. You were my CC. I thought, oh my gosh, this is awful. I don't know if I would tell my kids you were a poorly graded embryo. But the point is you would see a photo of all her girls. They're beautiful, healthy girls. It just doesn't matter. And so I think, to me, that's one of the biggest messages that I will tell people. It just doesn't matter that much. Aside from maybe just using it to decide which embryo we're going to put in, it ultimately will have amazing chances of having a healthy baby in the long term.
Right. Totally.
Okay, do you think we covered all the embryo grading questions and everything? Yeah. Okay, good. We will wrap it up for the week. And this was a special request. See how we respond right away with our special. If you guys have any other special requests, please let us know. And if you would be so kind and potentially leave us a review on our practice website, Peak Fertility, or on our podcast website, or on our YouTube, we would so appreciate the encouragement as we record these podcasts. And we will see you guys next week.
All right, have a good week.
Bye.